Hi everybody, this is Professor Mbewe, and I am going to continue our audio PowerPoints on the GI system. You can probably hear in my voice that I'm still not feeling well. It's just been a crazy weekend since last Wednesday and my voice was gone, and it's still kind of not quite 100% yet. Sorry. So I'm going to do peritonitis, Crohn's, and ulcerative today. And I'll probably take a break and then do more of these recordings tomorrow because I just need to rest my voice. I would have liked to do more of these ahead of time, obviously, but I didn't get a chance to do that. So peritonitis, your book describes peritonitis as either primary, secondary, or tertiary. We are primarily going to talk about the secondary types of causes that can cause peritonitis, and I don't necessarily need you to worry about whether it's primary, whether it's secondary, or tertiary. I just want you to be able to know that peritonitis has happened and what has caused the peritonitis. You know that peritonitis is essentially, I'm trying to get my highlighter here, that peritonitis, so I don't want the yellow one. Let's do red. You know that peritonitis is an inflammation of the peritoneum, and the peritoneum is the serous membrane that's lining the abdominal cavity. So what happens is in peritonitis, you get a spillage of intestinal contents. So they're supposed to be in a particular area, but now they're spilled into a very sterile peritoneum. So because that has happened, you're going to get weird things like massive fluid shifts. So you're going to get things like peritoneal edema. And some of the causative agents in particular for peritonitis happen to be bacterial in origin. So you've been given here some examples of what some of these bacterial things are. So they include things like E. coli, Klebsiella, Proteus, Pseudomonas, and Streptococcus species. Their most common causes of peritonitis include things like appendicitis, a perforated ulcer, diverticulitis, bowel perforation, abdominal surgical procedures, and peritoneal dialysis. When we're talking about peritoneal dialysis, we're talking about the dialysis that usually happens in patients who do continuous ambulatory peritoneal dialysis at home, and that could be because maybe they weren't following the proper technique, and then they get some bacteria, and then that spreads to the peritoneum where they're doing the actual dialysis. So we mentioned like ulcers, diverticulitis, bowel perforations last week, and we mentioned peritonitis being a complication, so that should not be surprising for anybody if you're looking back at your notes. Alright, so here you just have a picture of the same information we talked about. So gastric ulcers, duodenal ulcers, inflammatory bowel disease can be a problem, diverticulitis of the sigmoid, and appendicitis. So just some of the things that can cause peritonitis once again. Your clinical manifestations, they're going to depend on the location and extent of the damage. At first, the manifestations are very diffuse, but then they become constant and you get localized pain. So I do need you to be able to understand how peritonitis presents itself. So movement aggravates the pain. When you're looking at the, you're doing your assessment and looking at the abdomen, it's going to be tender, distended, and rigid. The patient may have what is known as rebound tenderness. So this is when the patient complains of pain upon removal of the pressure rather than application of pressure to the abdomen. So rebound tenderness is pain upon removal of pressure rather than application of pressure to the abdomen. And they can end up with things like paralytic ileus, primarily because of the decreased peristalsis that's there. So there's not a good blood flow going on, and that's why they're getting the paralytic ileus. You may also see things like anorexia, nausea and vomiting, fever, tachycardia, tachypnea. And if things get really, really bad, then you're going to get into things like hypotension. And all of this I'm hoping is making sense to you. If you don't treat this very quickly, so remember once again, you're getting abdominal contents that are spilling into your sterile peritoneum. Then obviously you're going to get things like sepsis and septic shock also may manifest. So nothing strange here so far, I hope, for you. So here you have what are considered your go-to diagnostic studies. So when they're always doing an aggressive assessment, they're going to see that the WBCs are elevated, and that's pretty much true in a majority of the cases. When they do a peritoneal aspiration, they're going to do a culture sensitivity because they're trying to figure out what the causative agent is. So if it's a bacterial infection, they'll try to figure out if it's any of those bacteria that we talked about earlier. Looking at your serum electrolytes, they'll be looking at your hemoglobin, hematocrit, and those tend to be decreased, especially if there's been some blood loss that's happened. If they do an x-ray of the abdomen, then they may see air or they may see fluid levels in there and maybe really distended bowel loops. So it's just showing you that they're seeing weird amounts of maybe air or fluid in places that it normally wouldn't be. Obviously, alterations in potassium, sodium, and chloride goes without saying because your electrolytes also may be out of whack. You're getting your abdominal ultrasound, seeing abscesses and fluid collections, and the CT scan also may show an abscess formation, and also things like MRIs could be done as well, right? And we've talked about abscesses before, and we've basically said that that's just purulent material, right? So funky, nasty things that are basically found. All right. So in terms of your complications, if it's not localized anymore, then you're going to see the fact that this infection has basically spread to other areas of your body. So what are you going to see? So we've already mentioned things like hypovolemic shock. At this point, you guys are very familiar with what that looks like. So thready pulse, increased thirst, restlessness, increased capillary refill time. All of this because of the sepsis that's going on in the hypovolemia. The specific sepsis, increased respirations, decreased BP, and this can become a major cause of death. Apparently, you may also see things like intestinal obstructions. The body's trying to fight off the infection that's happened, so you're getting things like bowel adhesions. So those can start growing, and you can end up with an obstruction as well from the peritonitis. So not good, because then your body is really getting messed up at this point. We've talked about paralytic ileus already, why that may happen, and of course acute respiratory distress syndrome can happen as well. All right, so we're going to look at our collaborative care and see what it is that we want to do right off the bat to kind of take care of this patient. And so under our medical management, we're giving medications to basically increase the intravascular fluid volume, because some of that fluid has leaked out, right? You may be seeing things like third spacing even that could start happening as well. So maybe we'll be giving 0.9% sodium chloride isotonic fluid to increase the intravascular fluid volume. We may be giving things like albumin even, because all of those things will help with pulling some of the fluid back into the intravascular space, right? We've talked already about the antibiotics, and we've said that, we give a broad spectrum until we know exactly what's going on. NGT, right? To suction, analgesics for pain, antiemetics, intestinal intubation, and suction to lower abdominal distension. So we're going to do what we can, right, just to decompress. Last week when we were talking, we talked a lot about NG tubes being inserted, primarily for decompression. So that's definitely something that we'll be doing here as well, to get rid of some of this extra fluid that's there. And obviously oxygen goes without saying. All right, so key thing is you want to remove whatever the infected material is, and you want to correct the cause. So you want to find out, okay, what caused the peritonitis, and then we fix that, and hopefully we will be able to resolve the peritonitis. So if it was an appendix that happened, then you want, maybe excision might be the way to go. If it was something that was specifically with the intestines, let's say, maybe there was a rupture or something, so maybe we need to resect that and maybe do an anastomosis, right? Anastomosis is just connecting two two pieces of either tissues or intestines. Maybe you cut off the piece that's dead or that's spilling, and then you connect the two pieces that are left. You're just connecting them, right? Maybe those are perforations, so maybe you do a repair. If there's an abscess, you drain it out, and then you still continue all the other treatments we mentioned earlier, obviously, like IV fluids, antibiotics, etc. But the point is you try to get to what the issue is. And if your patient has very extensive sepsis, where your bowels are affected now, then the patient may end up needing a fecal diversion that needs to be done. And we'll talk about fecal diversions later on. So if surgery is done, your two common post-op complications are wound evisceration, which means the wound basically just opens up, or abscess formation. Those are the two things you're worried about. So if your patient says to you that something just gave away, like it feels like something gave away, they need to report that. They're going to say that the abdomen is tender, is painful, but then if they specifically say also to you something just gave away, that's something that needs to be reported, because then it means that whatever repair they did is basically not holding, so that's not good. And then any sudden, keyword is sudden, any sudden occurrence of serosanguinous wound drainage strongly suggests wound dehiscence. So obviously you go to OR, maybe there's a little bit of serosanguinous drainage there. Ideally you just mark it, you monitor it initially if it's very little. But if it's sudden and it's a lot, then you're extra worried about that, making sure your patient is okay. All right, so peritonitis, so think about what's happened here, right? Contents have spilled into a sterile environment where they shouldn't be. This is not something that the nurse on the unit is going to be able to handle. So this patient needs to go to the ICU as quickly as possible. In the ICU, they're going to be able to do more hemodynamic monitoring. So maybe they'll put in Swan-Ganz catheters. They'll be monitoring central venous pressure, all those fancy things, arterial blood gases, all those things that we normally like to do in the ICU. So in addition of obviously pain, GI function, fluid and electrolyte balance, intake and output, all of that will continue. We've talked about fluid replacement. We've talked about antibiotics already. In some patients, apparently if you position them with their knee flexed, that can decrease tension on the abdominal organs, like they feel better. Rather than being stretched out. Let's say if they put their knees in, they feel better that way. So that's just something to consider for your patients, and once again, patient specific. You're monitoring vital signs. You are allowed to give sedatives for anxiety, but with anything, it's always cautiously, because you don't want that to mask your neurological assessment. For sure, once the patient is in the ICU, you will be doing some type of neurological assessment in addition to check what their GCS is looking like. So we've talked about NPO status with strict intake and output. We talked about NG tubes already, being connected to suction, and obviously you're monitoring any surgical sites if that is present in the patient. We're now going to continue the discussion and start talking about the inflammatory bowel diseases. In particular, we are going to talk about Crohn's and ulcerative colitis. So, by definition, your IBDs are chronic recurrent inflammation of the GI tract with periods of remissions and exacerbation. They are not sure what is causing IBDs, right? They have ideas about it, but they're not 100% sure. So when you're looking at Crohn's, you're going to see the other word being regional enteritis. So just make sure you really, really understand that these two words go together. So Crohn's, regional enteritis is the other word. And then they'll also describe ulcerative colitis, basically the whole time as ulcerative colitis. So both of these, right, can result in inflammation or ulceration, or both conditions happening of the bowel lining. In your book, there is a chart that compares Crohn's disease versus ulcerative colitis, so you want to just take a look at that as well. Apparently, the incidence of inflammatory bowel diseases is increasing in the United States. They're saying that men get ulcerative colitis more and that females get Crohn's disease more. there's a whole bunch of associated risk factors here. So you have family history appears to predispose people to IBD, especially if you have a first degree relative that has it. If you're living in cold weather, like in the northern climate, as well as if you're living in urban environments. They've mentioned also environmental agents such as pesticides, food additives, tobacco, and radiation. They've mentioned that things like NSAIDs can also exacerbate IBD. Um, let's see, allergies and immune disorders have also been suggested as causes. And both of these conditions apparently are more prevalent in Caucasian and Jewish heritage. Nationalities, so in particular the Ashkenazi Jews. So this is important in terms of your teaching as a nurse. You need to know this because you have to basically protect your patients from ending up with this condition. There is no specific cure. So usually when your symptoms have subsided or when they've performed a surgery, they consider that being a cure. But there's a really, really high rate of recurrence for both condition. And treatment is pretty much lifelong. So it's going to rely on medications to treat inflammation and basically maintain remission. So no specific cure, but the disease can be managed. All right, so now we're going to look at each of these conditions a little bit more deeply. So we're first looking at Crohn's disease. And so this is inflammation that basically can involve all layers, keyword being all layers of the bowel, and it can basically happen anywhere in the GI tract. But apparently it mostly happens in the terminal ileum and the colon. That's where it's happening the most. So it can happen anywhere in the GI tract, but primarily happens in the terminal ileum and the colon. So other name for it, we already said that was regional enteritis. We've already mentioned that there's remissions and exacerbations. They're not 100% sure what's going on, but they're thinking maybe there's some defect in the immune system, and then you're getting like bacteria invading your mucosa, and then you're getting what is known as an overactive adaptive immune response. So overactive adaptive immune response, keyword though being that this is just a theory and they're not really sure what's causing it. So the immune system becomes overactive, inappropriate, sustained, and you have a sustained inflammatory response. That's basically not good. So what are you going to see? You're going to see edema and thickening of the mucosa. You're going to see ulcers appearing on the inflamed mucosa. The lesions are not in continuous contact with one another and are separated by normal tissue. So the fact that so this is one of the distinguishing features for Crohn's. The fact that the lesions are not in continuous contact with one another and are separated by normal tissue, that is known as skip lesions, and that's where also it gets the name regional. So it's only regional, like particular regions that are affected. So lesions not in continuous contact, also known as skip, S-K-I-P lesions, and also the name regional enteritis comes from that as well. So the clusters of ulcers, they have a very cobblestone appearance. So this is just how they present themselves. So this is one of the features for Crohn's. In addition, in Crohn's, you may get things like fistulas, fissures, and abscesses can form as well. Apparently, you can also get things like granulomas that can happen. And when the disease becomes really bad, the bowel becomes thick and becomes very fibrotic, and your intestinal lumen narrows as well. All right, so you just want to start paying attention to what is unique about Crohn's versus ulcerative colitis. All right, so a brief mention of everything we just talked about. So skip lesions, the segments of normal bowel occurring between the diseased portions. Strictures can happen at the areas of inflammation, causing narrowing of the lumen. So one of the surgeries that can be done is a stricturoplasty. So because there's strictures, we can do a stricturoplasty. We'll get to that later. And obviously, you know, if any of this stuff leaks out, you're going to end up with things like peritonitis. You can get fistula formation, which can develop between areas of bowel with other loops of bowel. So a fistula is just an abnormal opening, essentially, that happens, or an abnormal connection that happens, right, between an organ or another tissue. So this can happen here as well. All right. So just this is just a page that's letting you know all the weird things that can happen under Crohn's. So Crohn's does have an insidious onset. It has primarily right lower quadrant abdominal pain and diarrhea that can happen that's unrelieved by defecation. So once again, you're paying attention to what's unique about Crohn's. So right lower quad abdominal pain and diarrhea unrelieved by defecation. You're getting scar tissue and the formation of granulomas that gives you crampy abdominal pain. Abdominal tenderness and spasms can happen. Eating stimulus, intestinal peristalsis, and the crampy pains occur after meals. So because it hurts the patient after they've eaten, so they've eaten something, there's peristalsis there, and then they get all this crampy pain, the patient starts to limit food intake. They don't want to eat. So therefore, they may not meet all their nutritional requirements, right? So they may end up with things like weight loss, malnutrition, and secondary anemia may happen because of that. So what does a patient look like? They're going to be thin, they're going to be emaciated from inadequate food intake and constant fluid loss that's going on. So may get ulcers as well in the membranous lining of the intestines and other inflammatory changes. So you're going to be getting weeping, edematous intestines that continually empties, and irritating discharge into the colon, right? So we've mentioned right lower quadrant pain and diarrhea that's unrelieved by defecation. We've mentioned the fact that when they eat, it stimulates peristalsis, so the patient doesn't want to eat anymore. So then we know that weight loss and malnutrition can end up being really, really a big problem for these patients. All right, so in some patients, the inflamed intestine can actually perforate, so that is not a good thing, right? So what are you going to be seeing in your patient? So you're going to be seeing things like fever and leukocytosis happening. Chronic symptoms in the patient include things like diarrhea, abdominal pain, steatorrhea, which is excessive fat in the feces, anorexia, weight loss, and nutritional deficiencies. Abscesses, fistulas, and fissures are common. So I do want you to make note of the fact that abscesses, fistulas, and fissures are common in Crohn's, not so much in ulcerative colitis. If the manifestations or the spillage goes beyond the GI tract, then of course you're going to be getting manifestations in other joints in your body, right? So how is that going to present itself? So you're going to be seeing things like arthritis, you're going to be seeing skin lesions, and they're calling these erythema nodosum. You're going to be seeing ocular disorders, things like conjunctivitis and oral ulcers. So just think about it. So there's a perforation that's happened, so now all these contents are going places they shouldn't be going. Remember, blood carries things everywhere, right? So then they're basically just creating problems, the byproducts of digestion, basically carrying problems in other organs in your body. So your clinical course and symptoms will vary. In some patients, they have periods of remission exacerbation, but in others, the disease follows a fulminating course. So remember what I told you about the word fulminating, that if you saw that, that means it's deadly, right? We talked about this, I think, under hepatitis. So fulminating means deadly. All right, some of your diagnostic studies, your go-to now are things like CT scans and MRIs that they're doing. It used to be that they used to do the barium study of the upper GI tract. So you'd swallow this barium thing, and then they'll do x-rays, and it will show you all the different constrictions on the segment of the intestines, right? It will show what they considered the string signs. Of all the strictures that they could see, but this is no longer considered the gold standard. So now they're primarily focusing on CT scans, MRIs. They can also do things like proctosigmoidoscopies to determine whether the rectosigmoid area is inflamed. Other things, endoscopies, colonoscopies, intestinal biopsies can be done as well. We're worried about blood loss, right? So maybe if there's a huge ulceration or perforation, then we're looking at our CBC, hematocrit hemoglobin levels. We're looking at our WBCs as well. We're looking at ESR, and obviously albumin and protein levels may be decreased, and that can indicate things like malnutrition. All right, so your complications have to do with just how the Crohn's happens. So we've already mentioned things like intestinal obstruction, stricture formations, perianal disease, fluid and electrolyte imbalances, malnutrition from malabsorption, fistula and abscess formation. The most common type of small bowel fistula. So remember, a fistula is a weird opening, a weird connection that happens. They are calling it an enterocutaneous fistula. So it's an abnormal opening between the small bowel and the skin. So this is something that you might see in somebody with Crohn's. And abscesses can be the result of an internal fistula that results in fluid accumulation and infection. So abscess, we know, is purulent material, so you know that it's infection primarily that's driving this, right? And apparently patients with Crohn's, this should say chronic Crohn's disease, not colonic. Patients with chronic Crohn's disease are also at increased risk of colon cancer there. All right. So now we're going to start talking about ulcerative colitis, and you're paying attention to what is unique about ulcerative colitis. So this one is recurrent ulcerative inflammatory disease of the mucosal and submucosal layers. So it's the mucosal and submucosal layers, and it's primarily the colon and the rectum. All right. This one is accompanied by systemic complications and a high mortality rate. And the key word I want you to think about is recurrent ulcers are going on, and it's the colon and the rectum here that's being affected. So it's not the whole GI necessarily as it was in Crohn's. So key word is multiple ulcerations, diffuse inflammations, and desquamation. So desquamation is literally shedding and peeling of the colonic epithelium, right? Then you're getting things like bleeding. So this is the first time we're seeing the word bleeding as being part of the manifestation. So the mucosa becomes edematous and inflamed. The lesions are contiguous, occurring one after the other. So these are back to back to back. Disease process usually begins in the rectum and spreads proximally to involve the entire colon. So it starts from the bottom and goes upwards. Okay. The bowel narrows, shortens, and thickens because of muscular hypertrophy and fat deposits. So here we're not seeing fistulas, obstruction, and fissures. They're not common here at all. Okay? All right, so what are our main takeaways under ulcerative colitis? So keyword, diffuse inflammation beginning in the rectum and spreading up the colon in a continuous pattern. Ulcerations destroy the mucosal epithelium, so you're getting water and electrolytes are not being absorbed, so you're getting things like bleeding and diarrhea. You're getting fluid and electrolyte losses. So these are similar to Crohn's here, the fluid and electrolyte losses and the protein loss, right? These two are the same. And then you're getting pseudopolyps, that tongue-like projections that you might see in your patient as well. All right, so here for ulcerative colitis, and there's not much I can do to help you remember these, you just have to know them. Your main features are things like diarrhea, passage of mucus and pus. A distinguishing feature is left lower quadrant, abdominal pain, intermittent tenesmus, because remember the rectum was the one where it starts and then starts going up. So remember the word tenesmus was that rectal pain that can happen, rectal bleeding. The bleeding can be mild or severe, so depending on the amount of bleeding, they can be pale, anemic, looking fatigued. So anorexia, weight loss, fever, vomiting, and dehydration, as well as cramping, tenesmus, and the passage of 6 or more liquid stools. So 14th edition has actually changed this to 6 or more liquid stools. 13th had 10 to 20 liquid stools, so it could really change. But I guess the recent research is showing that it's 6 or more. So, I mean, more can still be 20. So just know that there's a possibility for a lot of diarrhea. Disease is classified as mild, severe, or fulminant. We already know what fulminant means. You can have things like hypoalbuminemia, and anemia happening. 13th edition had highlighted hypocalcemia. And I could still see how all of that can still happen. Here they're highlighting decreased albumin levels, but really electrolyte imbalances for sure are going to happen. And of course, If it spreads, right, ulcerations spread, you're going to get skin lesions, erythema nodosum, eye lesions, uveitis, joint abnormalities, arthritis, and liver disease potentially. So this is pretty much the same in terms of what happened under Crohn's, right? So your assessment and diagnostic tests. So x-rays, studies are useful to kind of figure out what's going on. So colonoscopies, biopsies, CTs, MRIs. You're looking for things like tachycardia, hypotension, tachypnea, fever, and whether or not the patient is looking pale there. You're looking at the level of hydration, nutritional status. The abdomen is examined for bowel sounds, distension, and tenderness. The stool is positive for blood, right? So you want to make sure that, especially under ulcerative colitis, because there is that desquamation that's going on, that shedding that's going on, and it's an ulceration, right? So you definitely have to be monitoring all of your lab values here, right? So hemoglobin, hematocrit, WBCs, albumin, and all the other electrolytes for sure. All right, colonoscopy may show all the ulcerations. CT scans can show things like abscesses and perirectal involvement. But once again, remember, abscesses not so much under ulcerative colitis, but we're going to look for them anyway. You're looking at the stool very, very carefully for parasites. You're ruling out dysentery for being caused by common intestinal organisms, because remember we said they can be having really bad diarrhea. So if they're having 6 or more liquid stools, or 10 or more, or 20 even, you want to find out, okay, is this really ulcerative colitis, or did this patient come from another country? They ate something weird, and this is why they're having all of this weird diarrhea that's going on. So you really want to do an aggressive assessment to make sure you know what's going on. Some of your major complications under ulcerative colitis include things like toxic megacolon, perforation, and bleeding as a result of all the ulceration, vascular engorgement, and highly vascular granulation tissue that happens. Apparently, so keyword is toxic. So you're getting this huge megacolon that happens, but it's toxic. Remember, there's this inflammatory process that's still going on, right? So they have an overactive inflammatory process. It's extending into the muscles itself. It's inhibiting the ability to contract, and you're ending up with colonic distension. So signs and symptoms: fever, abdominal pain, distension, vomiting, and fatigue. So very general symptoms, right? But for the toxic megacolon, if the patient doesn't respond to treatment like within 24 to 72 hours of medical management, so maybe you've done our regular things like nasogastric suction, IV fluids, steroids, antibiotics. If none of that works within 24 to 72 hours, then you have to cut this piece out. Surgery has to be done. All right, so that's just something to know. So this is a major complication that can happen, primarily because of all the granulation tissue that's going on, and the fact that you're unable to contract and move whatever is in there along. Okay. In general, your book mentions that patients with IBD have increased risk of osteoporotic fractures because they have decreased bone mineral density. So if calcium, for instance, is not being absorbed, all that good stuff, right? We've already talked about this in previous lectures, so you can see why that would happen. If your patient is on steroid therapy, you can see how also that may be a problem for your patient, that they can be at risk for diminished bone density, right? All right, so this is just a picture of Crohn's disease versus ulcerative colitis. So you can see the skip lesions here under Crohn's, and it can basically happen anywhere in the GI tract, right? So you're looking around to see, okay, where are the problem areas? And then here you're looking at ulcerative colitis. So you know it's primarily from the anus going upwards for this one. Okay, keyword is superficial ulceration that's going on. All right, and it's continuous colonic involvement here, whereas here it isn't. Okay. All right, so in general, for inflammatory bowel disease, we're looking at a quick review here. So we know that we can get things like diarrhea, bloody stools, weight loss, abdominal pain, fever, and fatigue. You're going to split everything apart, and remember that bloody stools are more in line with ulcerative colitis, right? Doesn't mean it can't happen with Crohn's, but you're trying to figure out, okay, what's unique about each one. So the chronic disorders with mild to severe acute exacerbations and unpredictable courses of disease for IBDs. Crohn's, we've mentioned diarrhea, colicky, right lower quad, abdominal pain. Ulcerative, we've mentioned bloody diarrhea, left lower quad, and abdominal pain going on there. So collaborative treatment, rest the bowel, control inflammation, combat any infection, correct the malnutrition, alleviate any stress, provide symptomatic relief, and improve quality of life. This is what we're trying to do. So many different types of medications can be used to help your patient, right? So one category is aminosalicylates. So sulfasalazine is helpful for mild to moderate inflammation. Steroids are used. These are heavy-duty meds for fulminant cases. Immunomodulators as well for severe disease. So remember, so like these are like cancer medications. So Imulan, methotrexate, hopefully to autoimmune response. Then you have obviously antibiotics. An example given here is your Flagyl. All right, definitely the dietitian is going to be involved. So making sure the patient is well hydrated, giving them low residue diet, so not high fiber diet, right? Because we already have the problem of them pooping a lot, so we don't definitely want to make it low residue. High protein for healing, high calorie diet with supplemental vitamin therapy and iron supplement replacement if needed. Avoiding high fatty foods because that can put them at risk for more diarrhea. IV therapy, avoiding foods that exacerbate diarrhea. Milk being avoided, especially with the people that have lactose intolerance. Let's see here. Cold foods and smoking are avoided because both increase intestinal motility. So cold can actually create cramping. So that's not very helpful. So cold is a catch-22. In some places it causes cramping. In some places maybe because it does create the not the cramp necessarily, but it makes it cold. Let's say it makes a blood vessel cold. Therefore, you're not going to be having too much diarrhea because it's constricting, right? But in some patients, the cold causes cramps, and that's painful. That's not good. In some cases, the cold can stop movement of, let's say, stools going forward because it's cold, right? So that could be. It's a catch-22. But either way, I mean, who wants cold food anyway, right? So I guess you have to see how the patient responds. And then, obviously, parenteral nutrition may be indicated, which goes without saying. All right, and then you just have the group of medications, which I'm not going to go in depth here, but if you want to look to see whether or not these made it on your list, and then you want to pay attention to them. Okay. So still look at them, but just focus on the ones that are on your list. All right. So if all else fails, and you need to do surgery, then that's what we're gonna do, right? So what do we need to do for surgery here? So you're gonna do it if you're not responding to treatment. If you're getting frequent debilitating exacerbations, if you're getting massive bleeding or obstructions, maybe you're getting, perforations, you're getting tumors and just, like dysplasia, right? Tissues that are really just bizarre at this point, cancer formation, then you have to basically try to figure out, okay, what else can we do for this patient? All right, so you don't have to pay attention to the percentages once again, but know that quite a few patients with Crohn's disease will end up needing some type of surgery, and you're doing the surgery because you didn't respond to the other types of treatments that we had, right? So they can do a laparoscopic guided stricturoplasty, which we talked about earlier. So it's a common procedure performed for strictures of the small intestines. So they're basically opening up whatever narrowing there was. They can do small bowel resection. They're taking out any disease segments of their small intestines are taken out, and then they're resected. whatever pieces are left, they're connecting those pieces. Let's see, they can do things like a total colectomy, right? And if you do a total colectomy where they've taken out the whole colon, now they're going to have to figure out, okay, where is the stool or the byproducts of digestion going to be emptied out. So either they're going to do an ileostomy where they make an opening in your abdominal area. Let's say they bring up whatever piece of tissue they cut, they bring it out on your skin, or if the anus is still good, they'll connect the remaining piece down to the anus. So they've taken out the whole colon, but then they're connecting whatever piece was left to the bottom piece of your anus, let's say. So there's different ways that they can do these surgeries. So nothing is curative once again, right? Because it all depends on what's causing it. And then patients with ulcerative colitis, some of them can end up with colectomies as well. And so same thing, remember there's nothing being cured. If they've done surgery, they consider it cured, or if your manifestations subside, they consider that being cured. But it's all about just decreasing the profuse bleeding, perforations that are going on. So here they can do a proctocolectomy. So remember, it's not for everybody. It just depends on how what they need for you, right? So here it's a complete excision of the colon, the rectum, and the anus. So now they've, like, all of that tissue was diseased. So if your colon, your rectum, and your anus is diseased, then they have to figure out, okay, where are we going to connect the pieces that were right above the colon. So this is why I want you to have the picture of your anatomy with you at all times, right? Because you have to be able to know, okay, so they've taken out my colon, my rectum, and my anus. So what's left? And how have they now connected all of that, right? So what is the piece that's right above the colon? So where are we going to connect that now? So they may do an ileostomy where they just pull all of that out and put it in on the abdominal area. All right. So just always have a good sense of your anatomy. All right. So ileostomy, just by definition, and we're doing this loosely, is just a surgical creation of opening into the ileum or small intestine, usually by means of an ileostoma on the abdominal wall. So that's what they usually do. So especially when they've taken out the entire colon here, so then they just bring the ileum out. So you're basically just allowing for drainage of fecal matter, okay? And it is liquid. Your nursing stuff is really monitoring the stoma, making sure it looks good, right? There's usually an ET nurse, and your output may be as high as 1,500 to 2,000 mLs per 24 hours, but you're watching for things like hemorrhaging, abdominal abscess, small bowel obstruction, and dehydration, because you want it to be able to work like it should, at least as well as it should, all right? There are other things being described in your book. One of them is known as a continent ileostomy. They're not doing it as much anymore, but I wouldn't want you to be familiar with it because there's still questions on the NCLEX where they ask about what a continent ileostomy is. So with this one, they create a continent ileal reservoir. Keyword is a continent ileal reservoir is created. So there's a pouch here that they've made. So they've diverted a portion of the distal ileum to the abdominal wall, and they've basically created a stoma, okay? So this type, the key word is you do not need a fecal collection bag. You get rid of all this junk in there by basically inserting a tube and then draining the pouch, all right? So the GI effluent can accumulate in the pouch that they've created from the abdominal tissue, and then it's removed by means of a catheter that they insert through the nipple valve. This is how this works. So it's a creation of a continent ileal reservoir or a pouch, right? And then there's no fecal collection bag needed, and then we basically just insert a catheter into there, and then we drain it out. The problem is that you can get malfunctions of the nipple valve, which may require things like additional corrective surgery. And as I mentioned, they're not doing this as much anymore, but I still want you to be familiar with it. Okay. If the rectum is preserved, if the rectum is still good, they can do what is known as a restorative proctocolectomy with ileopouch anal anastomosis. So this is what they may do here. So what is going on? So it's connecting the ileum. So this is the key word was the rectum is preserved, right? So here they're connecting the ileum to the anal pouch that's been made, and then the surgeon connects the pouch to the anus, and then the patient basically can poop like almost as normally as they could, right? And so this is like a weird thing as well, and I don't necessarily need you to memorize this either. But the reservoir that they've created decreases the number of bowel movements by 50% apparently. And the biggest issue here is that they can get irritation of the perianal skin from leakage of fecal contents, and you may get strictures that may happen as well. All right, so just know that this one is out there. And this is basically the picture, so you can kind of look at it for a long time to see if you can make sense of it if you want to. What else did I want to tell you guys? Okay. All right, and then the rest of the slides are basically just the general stuff for a patient who has IBD. So we've basically talked about all the heavy hitters, the main points I wanted to make. So now you're just doing a general assessment. So you're reversing everything we've talked about, and you're assessing to see if anything is present. All right, so very aggressive assessment. So dietary patterns, so alcohol, caffeine, nicotine usage, you make sure that they're not doing any of this for IBDs, right? And that goes without saying. You're looking at your potential diagnoses very closely, and all of these are just your regular nursing diagnosis. There's really nothing unique about any of these. At this point, this is just your GI disorder nursing diagnoses. All right, potential complications. We've talked about all of these in some ways. Cardiac dysrhythmias, obviously if you're losing electrolytes, right, you're ending up with electrolyte imbalance, maybe potassium, etc., right? Especially if there's bleeding, right, you're losing potassium from that as well. So that would be a problem. All right, so your goals are going to depend on whatever your issues were, and we're at this point we're familiar with all of this. Okay, and if it's an issue of elimination patterns, then you're making sure that you're doing some teaching in regards to that. So relationship between diarrhea and food, activities or emotional stressors, right? We've talked about things that can affect your GI from our very first GI assessment slide. We talked about all the things that could affect your GI system. So this is where all of that comes into play. Okay. Giving medications as needed, monitoring your intake and output, giving maybe parenteral nutrition if needed, reducing anxiety. All of this comes into play as well. So make sure you're reading all of these page by page. I'm trying not to have the audio be too long, but I think you're good here. Your nursing implementations, right? So same things we've already talked about. Encouraging to avoid smoking, that goes without saying. And once again, you can email me if there's something that you is not making sense for you. All right, teaching. So think of everything that we've done already, and basically just make sure you're on top of all of that. All right, I don't want this to be an slide. All right, and then we'll talk a little bit about the patients with intestinal diversions, but I'll talk about this in a separate PowerPoint. I've talked about the continent ileostomy already, and really the main things is just making sure that the skin and the stomach care is there, and then we'll talk about whether or not you can irrigate some of these later. All right, and older people, they get a lot of IBD issues, 50s and over, and then some of them take a lot of meds, in particular NSAIDs, so that could be a reason why they are more susceptible. All right, so patient education basically has to do with you understanding the conditions really well, and then being able to communicate all of that information that you know to your patients. right? So there's a whole bunch of different foundations that you can basically tell your patient to be a part of. And this is, in a nutshell, what I want you to know about peritonitis, Crohn's, and ulcerative colitis, and just a little bit on the ileostomies at this point. Make a chart, make a table. I had given you a handout, and so you can actually pull some of this information and stick it in the chart by yourself as well. It's just I pulled out certain things for you. Okie dokie. Hopefully you could hear what I was saying. All right.